So, per se, opioid withdrawals, they are not life-threatening. Then why should we treat withdrawals? अल्कोहल विड्रॉल समझ में आता है, राइट? बिकॉज लाइफ थ्रेटनिंग होगा, डीटी होगा, वो सारी चीजें हैं, शीजर्स हो सकते हैं. बट व्हाई ओपियोइड विड्रॉल्स? I mean, if you don't do anything, also the patient will be free of these acute withdrawal symptoms in 1 week to 10 days. Then why should we treat? उसका मोटिवेशन ठीक नहीं है, इसके लिए नहीं कंटिन्यू कर रहा है. Right, but if he is motivated enough, then there is no problem. Why should we treat?
Opioid withdrawal is very distressing.
Right, that's the most important thing. The issue is, it's not life-threatening, but it's very, very distressing to the patient. So ask any opioid withdrawal or opioid-dependent patient. If you ask him, he'll say that the worst part of his life is when he experiences withdrawals, and he does anything and everything that is possible with him to see to it that he doesn't have withdrawals. Right? So resorting to illegal activities is also a desperate measure, move on his part to ensure that he doesn't have withdrawals. So that's why opioid withdrawal management is important. The goals of treatment here is to ensure that the patient goes through the withdrawal process with as minimal discomfort and pain as possible. Right? It also helps you in building a therapeutic relationship. If you take care of the patient, like the role play that we did, if you are able to manage his withdrawals the best way you can do with minimal discomfort, the chances of the patient continue to remain in the treatment will be much more. Right? You also get an opportunity to assess for any medical or other complications which might need treatment or referral, and it helps you in planning further treatment. And of course, you get an opportunity to educate the patient, the family members, and enhance the patient's motivation. Where can we do treatment? Is admission required for each and every patient? Yeah, we have been discussing since morning. One of the important things that we need to remember is that majority of the patients can be managed in outpatient settings. Right? Very few people require inpatient. The indications are the same as what Dr. Shilpa had mentioned in her presentation. If there is a comorbid physical or mental illness, you need to admit the patient. If the person has dependence on other substances also, then you will not be able to understand what kind of medications need to be given. So it's better that he is managed in inpatient. Poor psychosocial support is another indication for inpatient. Geographical distance was another issue that was discussed. Here also it remains relevant. And the same thing, that previous history of unsuccessful treatment in outpatient setting also becomes a reason, indication for inpatient treatment. Right? What's the process? Assessment as the first step. So once again, the detailed history of opioid use, other substance, ruling out comorbidity, past attempts at detoxification, the kind of psychosocial support that is available with the client, the severity of current withdrawal symptoms, right, and the motivation of the patient. So these are the issues that we need to look at when we do the assessment. Once again, client education reassures to the client that it's possible and it's not difficult. There are medications available, there are treatment available. Monitoring vitals if it is inpatient. Replenishing fluids, because diarrhea is a part of opioid withdrawal syndrome, so you need to replenish fluids. Screening of urine for drugs if possible. Not compulsory, but if it is available with you, you can do it. Associated medical comorbidity must be treated. Right? The important thing about opioid withdrawals is that pharmacotherapy has a primary role. In settings which offer different kind of treatment, for example, a therapeutic community setting, right? So there, patients are not allowed any medications for management of acute withdrawals, and they have to manage it without medications, which is called as the cold turkey method, right? It is not recommended. As rightly said, that it will lead to a high degree of relapse in patients. Two approaches in pharmacotherapy. One approach is you can gradually taper the dose of the primary drug that he is taking. What Dr. Shilpa was talking about in alcohol, in opioids that can be done, but that can be done only for patients who are using long-acting opioids. And the only opioids that we currently use in our settings where people might be dependent, physically dependent on long-term opioids is methadone, right? there you can gradually decrease the dose. Even people who are on opioid substitution like buprenorphine, there also we can gradually taper the dose of the buprenorphine, which is another way of managing withdrawals. But by and large, for majority of the patients, this is what we do, because majority of our patients would be dependent on short-acting opioids, right? So for them, you need to abruptly stop the primary drug and manage the withdrawal symptoms. How do we go about doing it? There are three approaches. One is opioid based, one is non-opioid based, and third is adjunct medications. Right? So it's in that order. If you have opioids, use that. If you don't, then go for the next. If that is also not there, then go for the third one. Right? So let's look at the opioid based detoxification. So the principle is the same here, that they act similar to the drug of abuse, but the only difference being you are giving in a controlled situation, right? And they are preferable to other agents. So these are the first drugs or medications of choice. It can be both full agonist or partial agonist. Full agonist, of course, it acts on the same receptors and produces the full effect. Partial agonist also acts on the same receptor, but they produce less than the full effect of the opioid. So partial agonist, the example prototype is buprenorphine, and for full agonist we have methadone, dextropropoxyphene, and opioid-like agent, which is tramadol. Dr. Atul, I'm sure he'll show in his slide much more colorful pictures of this, but basically this is what it is, that full agonist, they fit the receptors very nicely, and you have a full, almost the same kind of opioid effect, right? In case of buprenorphine, which is partial agonist, the fit is not total, it's imperfect fit. That's why you have a limited opioid effect. That's why it's a partial agonist, right? Buprenorphine based detoxification. The first thing is that he should not have used illicit opioids within 6 hours of the first dose of buprenorphine, which means there should be some withdrawal symptoms should be there before you give him the first dose of buprenorphine, right? Why should it be? Right, right. If the person has already opioids in his body and in his brain, then buprenorphine will displace, because its receptor affinity is much more as compared to heroin, for example, right? So as a result of it, buprenorphine will displace. So, and because it's a partial agonist, then instead of relief, his withdrawals will be more accentuated or precipitated. That's why you require an opioid-free time of at least 6 to 8 hours. That also depends upon what kind of opioids he is taking, but generally 6 hours is a good time period before you give him the first dose of buprenorphine. Dose and duration, how long? Depending upon what kind of setting that you are treating him with, is it outpatient or inpatient? The principle here is to rapidly increase the dose within the first 2 to 3 days. That goes with the principle of opioid withdrawals, right? They appear within hours and they reach a peak in 2 to 3 days. That's why you need to build up the dose. You need to give a high dose, and if required, increase the dose over the next 2 to 3 days, and then gradually taper over the next 7 to 10 days or 2 weeks, depending upon the comfort level of the patient, right? So this is what guidelines suggest about outpatient based regimen. That on day 1 you start off with 4 mg, day 2 increase, day 2 and day 3 you increase, maintaining for the next 2 to 3 days, and then gradually taper the dose of buprenorphine, right? And in inpatient, you can use lower dose than the outpatient setting. You need not go to the higher dose. You can also give here symptom-based, symptom-triggered treatment apart from the regular dose, which means you give a regular dose of 4 mg in the morning, and as needed you can top it up with another 2 to 4 mg. And by day 7 also, you can stop. This is what guidelines have to suggest. In our setting, what we commonly practice is that we give buprenorphine, we use buprenorphine 0.4 mg, and we give him, for example, 3 TDS or 334, depending upon his requirement. We continue it for the next 2 to 3 days. Required, we increase the dose, and gradually over the next 1 week, 10 days also, we gradually knock down 1 or 2 tablets every day, right? That's the way we do it in our setting, and we find it to be quite useful, the way that we prescribe to the patient, right? So that is the buprenorphine based treatment. Methadone, this is theoretical because methadone anyway is available in limited settings currently. So principles are similar to buprenorphine. Outpatient setting, you can taper the dose gradually. So day 1, you can bring him to 20 to 30 milligram. Then day 2 to day 4, continue with that. And reduce by 2.5 to 5 milligram every day. But it is over a prolonged period of time, at least 14 to 20 days that will require. Once again, here also in inpatient setting, the doses can be lower and the duration can be short.